And we're live in 5,
4,
3,
2,
1.
Good morning. Good morning. How you doing? I'd like to wish everyone happy Wednesday. My name is Clifford Pierre. I'm one of the fellows here at the Swedish Neuroscience Institute and Seattle Science Foundation. This morning, I'd like to introduce Dr. David Fiorella, who is a pioneer in the field of neurointerventional therapies, including the development of new devices and techniques for the treatment of cerebrovascular disease. He currently serves as the director of the Stony Brook Cerebrovascular Center and co-director of the Comprehensive Stroke Center in New York, and also is a professor of neurosurgery and radiology at the Stony Brook. He's actively involved as a principal investigator and co-principal investigator on numerous randomized clinical trials and research on new devices to treat aneurysm, stroke, and intracerebral hemorrhages. Today, we are excited to hear his talk on endovascular management of chronic subdural hemorrhage. And again, we thank you for being here, Dr. Fiorella.
Thank you so much for having me. I'm just going to share my screen here. Just want to verify everybody can see everything okay.
That's great.
Okay, fantastic. Again, I just want to thank you guys for having me. It's particularly special for me because, as I'm sure a lot of you guys know, that Dr. McDougall trained me, and I would have never had the opportunity to practice in this field if it weren't for his training. So I'm just going to talk a little bit today about the endovascular management of chronic subdural hematoma and just go through a little bit about how this field evolved and where it all came from, because it came on us pretty quickly, and it's really become established in our field now as sort of the standard management, standard practice almost over the past just 2 to 3 years. So I just look at a picture like this, a 74-year-old guy with some gait instability after a fall 12 weeks ago. And I look at this picture and it still sort of strikes me when I think about it is how did this ever become an interesting picture, an interesting case for an interventional neuroradiologist? These would be the scans that you'd get called on sometimes with the focal neurological deficit. You'd see it be a subdural and it'd just be sort of like, okay, on to the next case. And then all of a sudden this became something that we were interested in and frequently treating. And so how did this all happen? So I remember I was at a regional meeting in New York about a different trial, and I heard people talking about the Cornell group, and in particular Jared Notman, and they were just talking about his practice and how he had sort of developed this interesting component of his practice and really taken over the majority of what he was doing, and that he was using PVA particles to embolize the middle meningeal artery for the treatment of chronic subdural hematoma. This was like in the spring of 2018. And it struck me as something that was really peculiar because I had never heard of anything like this before. It just sounded like a weird thing to be doing. And whenever I hear about something like this, I usually sort of file it away. And when I got back to Stony Brook after the course, I just did a literature search to see what was available and what had been done in this area before. Because again, it was something that was just intriguing to me, the whole concept of it. And so I think when we look back at this, at least for the evolution of this globally, and particularly in the United States, Jared Notman deserves a tremendous amount of credit for really pioneering a lot of this work and a lot of these concepts here in the Western world. So in doing a literature search, looking at MMA embolization and what had been done in the field of subdural hematoma, I came across a paper that was published contemporaneously to my hearing about this in March of 2018 in Radiology. It was available online before this and had been submitted to Radiology in like 2017 or something, reflecting work that was done over the past 2 to 3 years by this group in Korea. And so when I looked at this band paper, it was a case control series where they looked at patients who they'd been treating with embolization more recently and then compared them to a historical control group of subdural hematoma patients prior to their institution of MMA embolization. And they were using this PVA particle embolization in 2 settings. One was for sole treatment, they called it. And these were patients with subdural hemorrhages where the strategy was going to be to just embolize these patients and see if they got better just with embolization of the middle meningeal artery. And then the other setting they were doing middle meningeal artery embolization for with subdurals was in a preoperative setting. So they were embolizing these people before they went to surgery. And then they compared these patients who were doing MMA embolization to a historical control group of patients. And they looked at these patients who were being managed conservatively, meaning they weren't going to the OR, they were just being watched or treated with steroids or something like that. And then another group of patients that were actually just going to the OR for burbles. And so, as you'd imagine, looking back over their practice history, they had quite a few patients in the historical control group, like 470, but they had embolized a fair number of them, 72 over the preceding couple of years. And their primary outcome was treatment failure, and they defined treatment failure as at 6 months having a scan that showed a large residual subdural, so something that was 10 millimeters or greater, or patients who were treated with the primary strategy of either watchful waiting or surgery, but that then subsequently had to go back to the operating room for either reaccumulation of their hemorrhage or because their hemorrhage enlarged or became symptomatic if they were being observed. And so what they found is that in the sole therapy group, so this is patients who either didn't go to the OR, were managed conventionally, and were either embolized or not embolized. When they embolized patients, 0 of 27 of them failed. So they had a 0% failure rate, meaning that all of them resolved their subdural hematomas to less than 10 millimeters at 6 months, and none of them had to go to the OR for surgical rescue. When they compared this to the group of patients who was managed prior to their embolization strategy, so patients who were just managed conventionally, either with steroids or watchful waiting, they noted that 56 of 67 of them failed, meaning that when they imaged them at 6 months, they either still had collections that were greater than 10 millimeters, or they had to go to the OR for surgical rescue. And so, again, with MMA embolization, they never saw failures, and with conventional management, most patients, almost 80% of them, around 80% of them were failing. So really a stark difference between the two groups. When they looked at their preoperative patients, so MMA embolization preoperatively, or patients who just went to the OR for surgery conventionally, when they went to the OR without embolization, they demonstrated an 18% failure rate. So that was 18% of patients who still had a substantial subdural at 6 months, meaning 10 millimeters or more, or patients who, after their original operation, they had to go back to the OR for reoperation. And this number, 18%, is not at all surprising. So in most surgical series, the rate of recurrent subdural requiring return to OR and reevacuation ranges anywhere between 5 and 30%. And a lot of that depends on the patient population in the series and on the technique that's used to evacuate the subdural. They found in these patients, when they embolized them prior to surgery, that they only had 1 of 45 that failed. So only 1 of 45 patients had to go back to the OR for reoperation. And in fact, that patient, they comment in the paper, was a patient who had a subsequent new head trauma after they had their original successful evacuation. And so really what these authors were reporting was essentially almost 100% success in the embolization arm, whether that was as sole therapy for the subdural or preoperative embolization to prevent surgical recurrence. And then the conventional management group, their success rate was 72%. But again, remember, in the medical management group, almost everybody failed. In the surgical management group, there were also failures that were improved with embolization. So my initial thoughts were, wow, this has a huge potential because, there's so many patients with this diagnosis. They estimate 60,000 new diagnoses of chronic subdural a year, which puts us at a much more common procedure than large vessel occlusion for thrombectomy if these patients perhaps were all amenable to embolization in some form. I wondered if the data were reproducible. So whenever you see a study like this where there's 100% success in the trial treatment arm and a high failure rate in the conventional treatment arm, it always makes you wonder if this is something that's real. It seems almost too good to be true from the original data presentation. I wonder why this would work, because again, coming into this field and not really looking at this disease process from any type of endovascular vascular standpoint, it didn't really make sense to me why this would work, because I'd always thought of this as a conventional surgical disease. It was going to be treated with conventional surgery. And where did this all come from? So where did this idea come from of embolization? How long has this actually been around? Is this something that was developed in the US by Nabin, or was this something that was being done in Korea for a long time? And so I wanted to look into all these things. So the first thing, why it would work. And so again, you don't really have to look that far into the pathology or the papers about subdural hematoma, the existing literature, until you see that really it is a vascular pathology, at least based on what we know about it from existing surgical studies and pathology studies. So it seems like there's some type of initial subdural bleeding that occurs that results in a reactive response in the dural layer with an ingrowth of neocapillaries. These neocapillaries are not competent, and so they leak blood into the subdural space. There are blood breakdown products, which are fibrinolytic, and that produces additional bleeding and additional inflammation. And this leads to a positive feedback cycle where the additional bleeding causes more ingrowth in neocapillaries, and neocapillaries leak more blood. That blood begets more inflammation, that begets more ingrowth. And so you end up in this positive feedback cycle. And there are a number of impressive pathophysiological drawings like this with all kinds of factors and stuff illustrating that this is going on. And so really this is just a problem of leaky membranes. And so you result in a situation where you have continuous recurrent bleeding, and this recurrent bleeding outstrips the rate of normal physiologic resorption of blood. And so basically there's a race going on between your normal physiologic factors in the dura and CSF and brain to resorb this blood, these blood products in the subdural space. And that's a race that's undergoing and losing to these leaky neocapillaries that continue to leak blood. And so as long as the bleeding is occurring at a faster rate than the brain is resorbing the collections will continue to enlarge and the patient will become more symptomatic over time. And so you end up with a physiology that favors continued accumulation as this positive feedback cycle. And so MMA embolization strategy really is one of to devascularize or eliminate or reduce the continued microhemorrhages into the subdural space and break the cycle of recurrent hemorrhage and inflammation and allow the physiological resorption of the subdural collection to occur at a rate that outstrips this rate of continuous leaking and to tilt this balance in favor of resorption. So we have these leaky membranes, we're going to perform an embolization, and we're going to change this physiology into one where the resorption rate is occurring faster than the rebleeding rate and ultimately leads to a resolution of the hematoma either spontaneously or after surgical evacuation removes some of the blood products and again reduces the stimulus for inflammation in the subdural space. And so then I wondered, where did this all come from? And so when you look back at the literature, the first reported case of middle meningeal artery embolization is in around 2000. And it, again, is a study from India. And it describes a patient who has multiple rebleeds after surgery to evacuate a subdural. And after the patient had rebled several times, they approached the interventional neuroradiology group to do embolization. They did an embolization with particles. And after embolizing the middle meningeal artery, it led to a cessation of these recurrent surgical evacuations that were required in this patient. So there was this case report in 2000. And then there are several additional case reports in the literature over the next decade or so, just talking about small series, 1, 2, 3 patients that had recurrent subdural hematomas who were embolized and that stopped the recurrence. There were 3 more substantial series. One of them was the Ban paper from Korea. One of them is another paper from Korea, again, looking at a retrospective series of surgical failures. And then this paper by Lincoln all, which was Jared and the group at Cornell's retrospective series of 49 patients where they performed embolization with PVA. So all the embolizations were occurring with PVA. And these were the initial case series, again, all indicating some level of success for this approach. So then in thinking about this, all these case series were using PVA particles. And as we know, PVA particles are dependent on flow. And if you've ever seen the middle meningeal arteries in patients who get subdurals, these are typically older patients with a lot of atherosclerotic disease. They have really small vessels. The vessels are oftentimes diseased. And there are multiple bifurcations of the middle meningeal artery before it gets to the level where it's supplying the meninges. And so if you think about particles that we inject, these contour PVA particles, we mix them up in contrast and inject them. They're irregular in shape and stellate in shape, and they tend to clump up not only in the hub of your microcatheter, but at bifurcations. And so these are typically leading to a proximal occlusion. The particles themselves are invisible, and so you just see contrast. And so a lot of times a lot of the operators who were doing these procedures were feeling like these particles were penetrating into the distal meninges and into the small vessels and capillaries, when in fact, in all likelihood, these particles were accumulating proximally and giving them proximal occlusions. But since they saw the contrast going distally, frequently in talking to these guys or talking in panel with these guys advocating for particles, they were under the impression that the particles were actually embolizing the distal circulation. But I didn't feel like that was true from our previous experience and just what we knew from particles. Again, these procedures were very time consuming too. Like if you've ever injected particles, even for epistaxis, you're just injecting these with small puffs over a long period of time. And the smaller the vessel is, the poorer the outflow is, the longer these procedures take. And so we felt like this was the right idea to do the embolization, but possibly the wrong tool. And we thought that the best way to do this was to potentially use liquid and embolics. So if the clinical pathology was distal at the level of the tiny blood vessels, it seemed like a liquid agent would be really advantageous in terms of penetrating to the site of the actual pathology. There were a number of other potential benefits to liquid embolization that I'll discuss as well. And then just from a situation of doing the procedure, if this is going to become a chronic, a constant procedure that we're going to be doing all the time, I just didn't really want to be in a situation where we're taking small microcatheters and injecting them for a half an hour on both sides to try to get PVA particles into the vessels. It'd be really nice to use liquid embolic because again, these procedures can take 10 minutes to do, and the injections are very quick and much more thorough, much more satisfying. And the embolicate, like I said, is better for a number of reasons. And then finally, just from a practical standpoint, this is really intriguing. The data were really interesting to look at, but none of this was done prospectively. It was all done retrospectively. These are all single center, self-adjudicated, non-core lab adjudicated, and non-externally monitored trials. And so really what was going to be needed to make this go in neurosurgery was to have a trial or a number of trials that were prospective that demonstrated that embolization was superior to non-embolization for the management of these subdural patients. And so with particles, which are really inexpensive, there's just nobody that's going to be interested other than sort of NIH or large funding entities like that in funding a trial. And so again, wanting to get a trial done quickly and efficiently, this really, in my experience, is best done with collaboration with industry. Just very, very difficult to get something like this going through means of governmental funding in any type of time efficient manner. And so first, making just the case for why liquid embolic agents from a physiological standpoint. So there are a lot of things about liquid embolic agents that make them more attractive for this particular application. First is distal penetration. So liquid agents get to the point of primary pathology at the level of the dura and at the level of the microcirculation, I think a lot better than the actual embolic particles. And this is something that we explored in the lab, and I'll go through that really quickly. In addition, the liquid embolicate is totally visible, so you can see where the embolicate is going. So we're going to start with a much more distal catheter position, which is going to get us away from a lot of the dangerous anastomoses of the skull base. So anastomoses with the recurrent meningeal artery that could take us in the ophthalmic and cause blindness. Anastomoses at the skull base with the petrosquamosal branch that could result in inadvertent embolization of the facial nerve and facial nerve paralysis. So we're being able to see the embolicate and having the radiographic image of the embolicate mimic exactly where the embolicate is something that's attractive in these cases. Again, liquid embolization is much faster and efficient than particle embolization, and the embolicate is permanent. So once it's there forever. And for these patients, because chronic subdural hematoma can be a recurrent problem, it seemed that having a permanent embolicate might be something that was beneficial over having a temporary embolization. So what we did is we have silicone models of the middle meningeal circulation that were created by Mentis. These are made from a composite of angiographic images of the external carotid circulation. And so these allowed us to connect to a physiological blood mimicking fluid on a physiological pump. So this really created a situation where we could test out various embolicates and see where they were distributed in the circulation. And so we compared Squid 18, which is a liquid embolic agent that's similar to Onyx. It's made by Bolt, with contour particles in various sizes. And it wasn't surprising to see that with the liquid embolics that we could reproducibly get from a single or two catheter positions an excellent casting of the distal vasculature all the way out into the very peripheral vessels, and that the distribution of the embolicate radiographically was what you see is what you get situation where when we took the models out and looked at the actual models that they perfectly mimicked what we saw with the injection of the liquid embolic agents. With the particles, we could create pictures like this, where injecting the particles created a opacification of all these distal branches with contrast. When we looked at where the particles were actually distributed in the model, you could see the particles were distributed proximally in clumps that particularly tended to occur at bifurcations. There really was no concentration of particles that got out into the smaller vessels over the periphery. And so when we looked at the relative distributions with the ethylene vinyl alcohol-based polymers, we could always cast the distal branches and get these embolic agents out very distally. the particles at smaller sizes even clumped up at branches, created multifocal proximal occlusions that were temporary. And same thing with the larger PVA particles, the occlusions were even more proximal. When we looked at the length of embolus distributed in the vessels and the average diameter of the embolized vessels, again, we saw that the squid product, the liquid product, could create a much longer contiguous embolized length of vessels, and the average diameter of the vessels that were embolized were much, much smaller than what we saw with the particulate agents. And again, this is reflected clinically in something that becomes very obvious clinically from your injections. This is a real-time injection of a posterior branch of the middle meningeal artery. And you can see that we're easily able to cast that distribution of the middle meningeal artery, and it's getting through the membranes and microcirculation even to back reflux the anterior branch all the way to its junction with the posterior branch. So just a much different physiological situation with liquids than with particles. And if our goal is to embolize the distal circulation and get at the point of pathology, seemingly something that was a much better strategy. So a quick injection like this is a real-time injection that's occurring within seconds rather than over 20 to 30 minutes, and a much more efficacious injection, and an injection where the embolisate distribution accurately reflects the distribution of the embolisate. It's a permanent embolisate. So we first started using Onyx to do middle meningeal artery embolizations at Stony Brook in May of 2018. And I talked to a lot of my colleagues about this. Adam and his group at Semps Murphy started using the same agent to treat subdural hematomas pre-surgically, post-surgically in a SOL therapy at Semps Murphy Clinic. And we compiled our cases that we've been doing since the summer, and we presented them at Val d'Isere in January of 2019. And so whenever presenting like a new concept like this, it's just really, it's such a fun and spectacular thing that we get to do in this field time and again. And I think that, Dr. McDougall has done this often as well, where you have something that's new and you have something in your slide deck that you're going to show people and they just haven't seen before. And so this was something that the audience, for the most part, was completely naive to. And so I just showed example after example of example for patients who we had treated with SOL therapy at Stony Brook, just with embolization with no surgery, showing subdurals that had completely resolved within months after embolization, of varying densities, of varying levels of loculation. So this is a patient who has subdural. Like these are the types of subdurals that look chronic, loculated, oftentimes recur because there are membranes that are tethering the brain. You can see here that after embolization, just over the course of a few days, you can see the subdural collection starting to reduce. And over the course of about a month, the subdural going from these loculated collections with significant mass effect to essentially complete or near complete resolution within the course of a month just after embolization. And so this was something that was favorably received at the meeting, and really started to stimulate people in terms of thinking about this procedure, in addition to the papers that had already been published. So we published our initial observations about the concepts of liquid embolization in JNS the next month in February of 2019. And it was remarkable how this took off after the initial publications from Cornell, our presentations and publications, and that within 6 months of that Val d'Isere presentation, embolization of the middle meningeal artery with Onyx became the leading indication worldwide for the use of Onyx in just 6 months of the presentations. And so then you can see also what happened with middle meningeal artery embolization and subdural hematoma in the literature. And so we talked about the first case report in 2000, and then sporadic case reports occurring over the next 10 years. And then just right here in 2018, you can see this gigantic spike in publications of various single center series describing middle meningeal artery embolization and subdurals. And this has just continued to increase in prevalence in terms of just the literature reports of these procedures and various single center and multi-center studies. And so just an explosion of these cases going on all over the place. And so we had developed right after our initial clinical experience a protocol for randomized controlled trial. And we presented this to Medtronic in 2018 prior to the Val d'Isere presentation. And Medtronic said they had too many obligations at that time, but we also presented it to Balt. And Balt had an embolic agent called Squid that they were looking to get approval for in the United States, and they needed to do some type of approval trial, but they didn't really have a plan. And so this really offered us the unique opportunity to really dovetail an industry objective, which was getting an FDA approval for their device with a specific indication that was unique. And here we had a potential indication for embolization of subdural hematomas, and then to use that funding to do real science, a randomized controlled trial to investigate this agent to see if this was actually a safe and effective procedure in a prospective, externally monitored, or lab adjudicated, randomized manner. And so the liquid embolic agent here again was squid. We started the trial in 2020, and the first enrollment in the STEM trial was in November of 2020. And so in designing these trials, it was really challenging because the literature for subdural hematoma is fairly convoluted. So subdural hematoma is treated for hundreds of years. If you go to any talk on subdural hematomas, you're destined to see some Indian skull with a hole in it, where they hypothesize that the ancient people were doing subdural hematoma evacuations or trephinations for this disease process. And despite the fact that this procedure has been around for hundreds of years, and there have been numerous papers published about it, there are still no evidence-based recommendations for the management of this disease, which is remarkable. So there are really no set criteria regarding when to operate on these patients or when to observe these patients. There's really no settled surgical literature on how to operate on these patients, whether they need a craniotomy, membranectomy, burr holes, or a SEPS procedure. So there's still a significant amount of controversy that. There's even more controversy about how and when to manage these patients expectantly. And there are very few data about how to image these patients and for how long. In the UK, for instance, they argue that there's really no indication to re-image these patients after surgery ever if they're doing well. And so really nothing in this field was settled. The data on the outcomes of these patients are very poor. The data on what happens to patients when they have to return to the OR for reoperation are very poor. So in looking at the literature, it was something where there really wasn't a great starting point in terms of how to design a trial. And so another thing that you run into in the absence of literature to tell us what to do, what you find is when you talk to people, there are widely varied practice patterns. And these are variable from institution to institution and between physicians within a given practice. I know in my practice, there was just tremendous controversy about how to operate and when to operate on these patients. But fortunately, I'm in just an incredibly supportive neurosurgical group of partners who are really, really open to endovascular therapies. And so we went fairly quickly at Stony Brook to a strategy of embolization for subdural hematomas with surgery reserved for patients who fail embolization. But one thing that I found in talking to my colleagues and then sort of setting up a trial and talking to physicians from the outside is that when you have one of these situations where there are no data, it really is not a field that's governed by science, but really a field that's more governed by religion. And surprisingly, in the absence of sort of science or evidence-based recommendations, I find that physicians are even more kind of bound to their practice patterns and reluctant to give up their practice patterns. And so when designing a trial here, you really have to design around that for a trial that's going to be pragmatic and a trial that's going to be widely accepted, where you're going to be able to randomize patients into the trial. You're going to be able to get participation from a bunch of institutions. And so we wanted to design a pragmatic trial of middle meningeal artery embolization that didn't disrupt local and individual standards of care, so that it would not only reflect how middle meningeal artery embolization was going to be used in the community after the trial, but also would allow enrollment. So we wanted to faithfully reflect how the device was being used off-label for middle meningeal artery embolization as an adjunct to standard management. So not to replace surgery, not to replace standard non-surgical management strategies, but to see how this could fit in as an adjunct. So again, in initially designing a trial, our whole goal was to design a trial that was positive to gain a foothold in this area, not to supplant or replace surgical therapy or non-surgical therapy, but to see how we could function as an adjunct to those therapies and not disrupt any local practice patterns. So the hypothesis statement really wasn't, does MMA replace surgery, replace standard management? But the hypothesis statement was going to be, does adjunctive MMA embolization improve outcomes when added to standard management? So not is MMA embolization better than standard management, but can MMA embolization help standard management in these patients? And I always feel like this is the best sort of first question to ask when you have some type of new therapy, is to try to do it without disrupting current practice patterns. And so what is standard management? So as we talk about standard management, surgical evacuation for a lot of patients, but then also for a lot of patients, non-surgical management or observation. So patients who are too sick for surgery or patients who aren't that symptomatic but still have large subdurals that need some type of management or observation closely. These are the patients that we're talking about. So we designed the trial as follows. So you have a subdural patient that comes in, they're assessed by the neurosurgical team at admission. If that patient needs emergency surgery, those patients are excluded from the trial. So those patients need to go to the OR. Those patients can't be watched for any period of time. They have a focal neurologic deficit, a blown pupil, acute subdural collection, acute or chronic subdural. They have to be immediately decompressed. So these aren't optimal research patients. They're harder to consent. They tend to have more complications. They may not survive their initial subdural, so the follow-up may not be good. And so we wanted more stable patients. So the types of patients that we were going to include in the trial were patients who could be managed surgically, but those patients didn't require emergency surgery. So if the neurosurgical team said, yeah, this patient needs an operation, but they don't need an operation 2 o'clock in the morning, they can wait until the next day or the day after that, but eventually this patient needs surgery. So those are good patients for a trial, allows us time to consent them to make sure they're stable from a medical standpoint. And then non-surgical patients, so patients who might be too sick for surgery, patients who weren't incredibly symptomatic from their subdural, so headache, head pressure, some cognitive slowing, patients who you could afford to watch over time. These were good patients for the trial too. So the patients were allocated by the neurosurgical team into one of these two categories, either surgical management or non-surgical management. At that point, they were randomized. So if they were in the surgical management arm and they were randomized, they either got embolization and then operative treatment or just operative treatment alone. For the non-surgical patients, those patients either got embolization or standard non-surgical management. So whatever was normally being done at the institution, this could just be serial imaging. Some institutions were treating these patients routinely with steroids. Some institutions were routinely treating these patients with statins or things like that. Reversal of antiplatelet or anticoagulation agents, holding these agents. So whatever they normally did, we just encouraged them to normally do that. So basically, embolization here was just an adjunct to whatever management was normally being done. We were stratifying these patients clinically, and then these strata were used as strata in the randomization to create equal groups of embolization, non-embolization in both the surgical and non-surgical arms. And so the ultimate comparison was going to be embolization versus non-embolization with standard management in both groups. So group A was going to be standard management without embolization, whether that was surgical or non-surgical. Then we're going to statistically compare this to standard management with embolization, either surgical or non-surgical, with embolization before surgery or embolization as sole therapy. And so again, the advantages of the study design was that we just allowed the institution to do their normal standard management. They just have to declare that up front what that was going to be, so it doesn't disrupt any local or individual care patterns. And it would allow all the participating institutions to enroll both of their surgical and non-surgical, non-emergent subdural patients into the trial. And then this trial was pragmatic because it was going to reflect exactly how middle meningeal artery embolization would be practiced and was currently being practiced at these institutions. And so then what are the endpoints? Like, how do you measure the effect of middle meningeal artery embolization was the next thing once you have the trial structure. So the first thing is this effective? So clinically, what would be the best endpoint for middle meningeal artery embolization? So after surveying literature, felt the best clinical endpoint was going to be the same endpoint that the band paper used, and that was whether these patients needed reoperation if they were originally managed surgically, or whether these patients, if they were managed non-surgically, ultimately ended up needing to go to the OR for evacuation of their hemorrhage. So was middle meningeal artery embolization effective in reducing operation or reoperation surgical rescue in these patients? The second endpoint for efficacy was going to be a radiographic one, meaning does middle meningeal artery embolization reduce the amount of residual subdural hematoma after surgery or after watchful waiting at 6 months? So to look at their CT scans and to look at them clinically to see if they required operative rescue. The second category then was, is this safe? So does middle meningeal artery embolization result in greater rates of stroke, death, or myocardial infarction than standard management alone? So was this procedure harmful? Were you getting complications during the procedure, after the procedure, that potentially would suggest that even if it did have a clinical benefit, that there was could be outweighed by problematic safety data? And so the clinical endpoint of operation or reoperation is important, again, because the surgical management arm, the surgical literature had described recurrence rates after an original surgical evacuation of between 20 and 30%, or 2 and 30%, depending on what the surgical technique was, what patients were included in the study. And when we look at surgical recurrence, there's really only one reference for this, but surgical recurrence is associated with poor outcomes. So if you have a patient who has a subdural, they go to the OR and they get evacuated. If they have reaccumulation of that subdural and have to go back to the OR, there's a one reference, Rowe et al., that looked at patients like this, and they saw that patients who had to go back to the OR had a 67% rate of poor outcome versus 5.1% poor outcome in patients who were successful after their first subdural evacuation. But again, this is a little bit convoluted because the same features that suggested poor outcome were also the similar features that were associated with reaccumulation of the hematoma. So the data is a little bit murky, but definitely suggests that if you have to go back to the OR after initial evacuation, that wasn't good. There are really poor data describing the outcomes of patients who are managed non-surgically. These are primarily from small studies of drugs, case series of things like steroids or statin therapies or reversal of antithrombotic strategies or actually pro-coagulant strategies. And these reported rates of spontaneous resolution of anywhere between 5 and 50%. But they are again small series. There were no reliable estimates of the percentages of observed patients who ultimately required surgical rescue. And there were no data at all for non-surgical patients who ultimately required surgical rescue in these series. And so, again, the data weren't very good to tell us how these patients did, but at least we had at least some benchmark in terms of what the resolution rates were and what the rescue rates potentially could be for these two groups. In terms of radiological endpoints and thinking about how to do this, Bandit used reduction of subdurals to less than 10 millimeters in greatest thickness. So we had some fairly reliable baseline data from BAN that we could use to model the study if we use this 10 millimeter cutoff radiologically. 10 millimeters is easy to measure on a CAT scan, and so we chose to go with this. Some operators have gone with reduction of volume by more than 50% at between 3 and 6 months. Measuring volume of subdurals, because they are presenting in shape, can be very difficult. It requires hand segmentation and volume evaluation in that manner. And so it's really difficult to measure this reliably. And it's difficult to do this in an automated way because the density of subdurals is so wildly variable. And so oftentimes even AI-based programs for volumetric measuring are challenged by this. In addition, if you start out with a really big subdural hematoma, even a reduction in 50% of volume can leave you after 6 months with a fairly large subdural hematoma remaining. And then if you have a small subdural to start out, even insignificant residuals could still be counted as failures. So say you have a 10 millimeter, 11 millimeter hematoma to start out. Even if you reduce the volume 50%, you could, or less than 50%, you could get it to 6 or 7 millimeters, which would be probably clinically insignificant. That would be counted as a failure if required, if you're requiring a 50% volume reduction. Complete resolution at 3 to 6 months also seemed too stringent because clinically small subdurals would fail here. And then radiologic stability at 3 to 6 months. If we're really enrolling patients with significant subdurals in the STEM trial and all the existing RCTs typically require a subdural of 10 millimeters or greater in thickness to get in. Radiologic stability at 3 to 6 months, especially if the symptoms are still there, may not really be that meaningful in these patients. For safety endpoints, we decided again to look at disabling stroke, death within 30 days, neurological death within 6 months, and MI. So disabling stroke is of interest, especially in this population who are typically older, because these patients are often on antiplatelet anticoagulation medications. And so this presents a clinical conundrum of discontinuing these medications, resulting in possible ischemic complications, versus continuing the medications, resulting into a situation where you're challenged surgically with bleeding postoperatively, or you're challenged with observation with continued accumulation of blood products in a patient on anticoagulation. And so specifically in the BAN paper, what they saw is a significant number of their poor outcomes in patients who were not embolized were in patients who had their antiplatelet anticoagulant medications reviewed and had MI or peripheral vascular complications related to their initial indication for anticoagulation or antiplatelet therapy. So something interesting to consider. And then death is something interesting to look at in these patients because death is subdural hematomas is a sentinel health event. So if you look at patients with subdural hematomas, they're much more likely to be dead than their age-matched cohorts within 1 year. And some studies say this is as high as 30% mortality rate at 1 year if you have a subdural hematoma. One question that we would get all the time is why not use modified Rankin as an endpoint in these patients? And I'll touch on that in a second. But in all of the studies that are ongoing, typically operation or surgical rescue is an endpoint, residual hematoma collection 6 months or 3 months is an endpoint, and in some of the studies, the stroke, death, or MI is an endpoint. But modified Rankin is an endpoint that the regulatory agencies often focus on, and we are collecting that in all the studies and analyzing it, but it is not the primary endpoint. Patient-assessed quality of life is important, and that's built into a lot of the studies. We're looking at neuropsychological outcomes in STEM, and this is important because chronic subdurals are oftentimes a cause of neuropsychological slowing and dementia in these patients. It may be a underdiagnosed etiology for dementia in a lot of the elderly population. And then healthcare utilization in terms of hospital days, ICU days, and readmissions for subdural mortality. So what about modified Rankin? We use that as an outcome in a lot of the clipping versus coiling studies. We use this as an outcome in the stroke studies. Why not subdural? So subdurals are a lot different than stroke and subarachnoid hemorrhage. So in subdurals, these patients definitely have excess mortality compared to age-matched controls. But in these studies, interestingly, when they look at these patients' outcomes over time clinically, really patient factors weigh into their outcomes much more than factors relating to subdural, like size and density and shift and things like that. So if you look at the causes of death in these patients at follow-up, it's much more like the data that look at hip fracture as a sentinel event or things like that. It's where you look at why these patients are dying at follow-up. They're dying of coronary artery disease, oftentimes complications related to dementia or Alzheimer's disease, sometimes ischemic stroke, cancer, or trauma, things like that. In fact, if you look at causes of death in the study by Rahula on a large cohort of patients in India, the subdural hematoma was only indicated as a primary cause of death in only 6% of patients. And so it's not that straightforward, the relationship of subdural hematoma to the actual outcome in these patients. And so if you think of this just pragmatically, so if you think in a subarachnoid hemorrhage study, a 50-year-old female with subarachnoid hemorrhage is the kind of patient you'd see in ISAT, the kind of patient you'd see in BRAT, or a stroke study, a 70-year-old male with, say, a left MCA occlusion. If this index patient is dead or disabled at 3 months or 90 days in the case of stroke, or 6 months in the case of subarachnoid hemorrhage, it's most likely related to that index event or its treatment. So 50-year-old female who does bad after a subarachnoid hemorrhage, if she's disabled at 6 months, that's very likely related to the subarachnoid hemorrhage or the treatment of her aneurysm. Same thing with the stroke. If you have a patient who has a left MCA occlusion, it's very likely that if they're dead or disabled at 90 days, that disability is likely either directly related or indirectly related to their MCA occlusion. If you think of our chronic subdural patients, you have an 80-year-old alcoholic patient with coronary artery disease, COPD, diabetes, probably on Coumadin or something like that, who comes into your clinic with gait instability, headache, and mild cognitive slowing with a 12-millimeter subdural. So this patient would be a candidate for any of these trials with a small symptomatic subdural greater than 10 millimeters. But again, if this index study patient is dead or disabled at 6 months, it's just as likely that they're dead or disabled either from coronary artery disease, ischemic stroke, dementia, or trauma than it is from their subdural. So it's just a much more difficult event than what we typically look at in our cerebrovascular and endovascular studies. And so that's why modified Rankin probably isn't a great measure of a primary endpoint in these patients if you want to do a positive trial. So why collect modified Rankin? Why is it important? Well, it is really important to assess our patients for excess morbidity and mortality related to the index treatment if they're not meeting a clinical primary endpoint. So in other words, for patients who do well in the trial, so they don't meet a clinical primary endpoint of having a major stroke or dying or having to go back for emergent surgical rescue or something like this, for those patients who are doing well clinically, we want to make sure that the study intervention isn't causing an excess of poor outcomes like death or disability from another cause. So for instance, there was a large study published in the England Journal that was performed in the UK where they were using steroids to treat patients with subdurals. Almost all those patients went to surgery. It was like 95% of the patients in the study went to surgery. And what they found is that even though steroids reduce the risk of recurrence in these patients, their outcomes based on modified Rankin scores were actually poorer. They did worse from a standpoint of outcomes. And again, that data is also still a little bit murky, but suggested that this primary treatment, even in patients who did well with it, still were having some type of complication potentially related to the primary treatment that was resulting in them having a poor outcome. So it's still important to assess this, but this really is not a great primary endpoint for us. And so how are these trials progressing? Well, one of the reasons I wanted to present this today is that this week, on Monday, we completed enrollment in STEM. So 310 patients were randomized out of 310 patients. So STEM is now closed to enrollment. Membrane is the prospective trial being done by Johnson & Johnson Sarah Novis. They've enrolled 228 out of 376 patients. As of last week, Medtronic, who are running 2 large prospective trials, one in the United States called Embolize, had enrolled 450 out of 600. Magic MT is running in China. They've already enrolled 700 out of 722, so that study should be finishing imminently. And there are 8 additional randomized controlled trials enrolling worldwide, all of which have a very similar protocol to the 4 trials listed here, which are essentially almost identical in regard to their structure and in regard to their endpoints. And so we really have a great situation going on with all these randomized controlled trials similar to stroke. And the reason I wanted to particularly present this to the SNI today is that these are the STEM study sites. So congratulations on finishing enrollment. But what I want to do is really specifically congratulate the group in Seattle because they are the leading enrollers in this trial. This is really a landmark trial, and that it's the first randomized controlled trial of embolization of the middle meningeal artery for subdurals. This trial would not have been able to get done if it wasn't for the contribution of the group at Seattle. And so I just can't thank you guys enough for your support of the trial and your great work in this trial and the dedication to science and patient care that you guys have demonstrated at the SNI in treating these patients and in doing science to advance this field. And so moving forward, we have an in-spirit data sharing agreement amongst all of the large sponsors of these trials. And so similar to the Hermes analysis that was done in the thrombectomy trials, we should be able to do that in these trials with a tremendous amount of statistical power to get answers to some really great questions regarding subdural hematoma in these patients. So we really don't have a great natural history of the disease in these patients that's been demonstrated, but we have a tremendous number of patients that were treated conservatively in these trials who were not treated with surgically, were not treated surgically, were not embolized. So we'll know what is the natural history of subdural hematoma when it's not treated with surgery, when it's not treated with embolization. We'll be able to compare that to embolization. We'll know the complications of embolization. We'll have a very good number in terms of what are the outcomes when patients have to go for operation or reoperation in these trials. We'll know what their neuropsychological outcomes are in many cases with subdurals that are treated with conservative management or embolized. Really just a huge wealth of data, clinical data, economic data, healthcare outcomes, patient satisfaction, quality of life outcomes from all of these trials. And so really our knowledge about this disease process within the next 1.5 to 2 years will be tremendously different because of the support of all these sponsors, these current ongoing randomized trials, and the supports of the great institutions like SNI who are interested in randomizing these patients into these trials. And then future trials we'll be able to do now with all these benchmark data to do power analyses and stuff to compare embolization to surgery, to sort of see if embolization as a first strategy could potentially supplant surgery as a first strategy for many of these patients, and to see if that would have outcomes benefits in these patients or reduce costs in these patients. And so really a very promising field now, a very promising field going forward, and something that I think will fundamentally change not only the field of endovascular therapeutics, but possibly neurosurgery and medicine going forward. So really exciting times just coming up in the very near future. And again, thanks to institutions like yours for participating in these trials and advancing this field as you have. And so thanks again for taking the time. That's my presentation today, and I'm very happy to take any questions from the group.
Again, Dr. Fiorella, we thank you again for this wonderful talk on the management of subdural hematomas. I'm going to open up the floor for some questions. I don't know if Dr. Monteith or Dr. McDougall would like to start. If not, I can ask some questions.
Yeah, if I could, thanks, Dave. That was great. And I really just want to sort of point out what a master class you just gave on, both the strategy and the tactics, the technical thinking that goes into advancing a field like this, because there's so many little nuances in there about, how you designed the trial, what your thought process was with you and Adam in designing this, and really finessing the whole community in terms of, getting engagement with it and having them understand that it's not, a winner take all sort of thing, that it really is integrating into the community and looking at, the ways to do this. And I think there's a lot of little points in there that people who are thinking about doing trials or anything to advance the field really should be paying attention to the way you thought about this. And the other sort of point that I wanted to bring out was there's this, you see it throughout history, there's this illusion of inevitability, that it seems like, this is so obvious in hindsight. It's so clear that this was going to happen, almost just couldn't be stopped. And that just isn't true at all. And, I think of the very early days of this, when you were getting this going, that European trial with the steroids was about to be announced. And that could have gone a very different direction. The steroids could have been highly effective, had better outcomes, and that would have, crushed this potentially. And you think of Medtronic, who had so much to gain with this, with Onyx, who passed on it, and then quickly did the, 180 whipsaw. So there's a lot of things that happen to bring all this about, and it's really paying attention to detail and doing it right, the way you and Adam did to design this. So I'm really grateful for that. Steve has his hand up, but I did see in the chat there's just to be a little bit devil's advocate, people argue a lot, and I think somewhere in this, in your sub-analysis, you'll sort this out, especially when you get the pooling of events. But really, the technique and the degree of penetration, you went into a lot of detail about why not to use PVA, and yet the results of PVA have looked great. So, do you want to talk a little bit about technique and the importance of that?
Yeah, so there, again, it's important to note that there are really no prospective trials of PVA. All these, again, are small single-center retrospective case series that are self-adjudicated to a large extent. Many of them, like the series from Cornell, isn't looking at resolution of subdurals, it's looking at stability of subdurals at very short time intervals, so typically like 6 to 12 weeks, and a lack of reoperation over that period of time. So there really aren't great data about PVA, and I think PVA probably works. I think proximal coiling probably works to some extent, but in doing a trial, again, you want to give it the absolute best chance it has to be successful. And so in terms of getting a successful embolization that gets to the level of pathology, I thought that the best potential thing would be to take our best shot up first. So if we think of like the thrombectomy trials that were all initially negative, I think we kind of all agree now that while some of the things in terms of patient selection played a role in that, a lot of it was we just didn't have the right devices to do the trials. The Mercy device wasn't very good for clot extraction. So I felt like this provided us, I thought, with the opportunity to put our best foot forward in terms of getting good, effective embolizations of these patients. And then, various other reasons why it might be better to use liquid. So more distal catheter position as possible, avoiding a lot of the dangerous anastomoses, being able to visualize the embolisate, knowing what you're embolizing, and then the ability to do a correlation afterwards of looking at the scans for these patients, the dynastiques and the radiographs, and being able to correlate like extent of penetration and resolution of the hematoma to determine how important that is. And so I think in the future, there will definitely be room if people are interested in doing, say, PVA particles versus liquid embolization to see which one is relatively more effective. But in designing a trial with clinical endpoints and safety endpoints, I think taking all that into account, that liquids gave us significant advantages for some of the reasons that I've laid out. But yeah, I don't mean to say that particles wouldn't work or don't work. I just think the percentage of patients they would work in is probably not as great. But I don't know that. I don't have great data for that.
Yeah, great points. Steve, do you want to?
Thanks, Cameron. Thanks, Dave. That was a great talk. It always is. And thanks once again for the opportunity for being in the trial. We've thoroughly enjoyed it, and it's been very well designed and executed. My question was, in terms of pushing the envelope with stroke over the last 10 years, we've moved from kind of slam dunk cases with great looking CT scans to now doing these sort of fringe cases where patients are maybe not going to have a great outcome, and we're making it slightly not quite as bad. Do you think that we're going to do that with subdurals? We're going to be taking people with, say, maybe more than 50% acute component? Do you think the next stage is going to be pushing the envelope of indications for some of these pretty unhealthy elderly patients?
Yeah, I think there's a number of things that will happen. I think if these trials result and they're positive, that I think most subdurals that are treated will have some type of embolization, whether it's preoperative, postoperative, or a sole therapy. I think the key trials going forward would be ones that looked at so structure similar to like the BRAD trial, say, where you say is embolization first a better strategy versus surgery first a better strategy for patients who could be, equally as well treated with either way. So if patients could be observed, are you better off doing embolization as a first pass or doing, surgery as a first pass in these patients? So I think there's a lot of trials like that will explore that. And there's just so much interesting stuff coming down the pike with this, and so many opportunities to do additional research in this anatomy. And just so many things to look at: the resolution of headache in these patients, the resolution of dementia and cognitive impairment in these patients. But it's good for so many different reasons, from a health economic standpoint for the patients, and then for our field. Like, if you just think about pragmatically the field, so we have a situation with large vessel occlusion and acute stroke that now all practices have to have 24/7 covered, 7 days a week, and all the staff to accommodate that. To have a large influx of procedures that can be done relatively electively does a lot to support the ability to provide these stroke services after hours in groups, throughout the country. And so it is, if this is good for patients, it makes sense from a healthcare economics standpoint, it really would do a lot to support our field in ways that would help us be more effective in treating stroke patients and adequately staffing institutions to treat stroke patients too. So there's just so many potential spin-off benefits of this if we can prove this out correctly, and if it does actually work well, if it's validated in trials.
Thanks.
I have a question with regards to what you mentioned prior to the trial, just some of the dogma versus variations in practice patterns in non-surgical versus surgical. But in what you've noticed, at least, I don't know if you got a chance to outline this in terms of the criteria for subsequential radiographic monitoring, in terms of time frame, for both surgical and non-surgical. I don't know if we got into the weeds of that with regards to the trial in terms of the time frame for patients who you said, like the UK study mentioned, you don't have to ever image these guys once you operate versus those we're operating and not operating on.
Yeah, the UK trial is interesting because that was completely questionnaire based. It's not dissimilar in many ways to what was done in ISAT. So really the only 6-month follow-up that those patients got was a questionnaire, or if they didn't respond to the questionnaire, a phone call to their home to see how they were doing from a Rankin. So this wasn't like an independent Rankin evaluation and an in-person examination. So in the prospective trials, we're encouraging imaging at 1, 3, and 6 months. The primary outcome is at 6 months, where a CT scan is mandated to be compared to the immediate post-embolization or post-enrollment scan. So that 6-month scan is the primary endpoint. In STEM, if you fail the 6-month endpoint, meaning you still have a radiographic failure, but clinically you've been successful, so you have a 10 millimeter larger hematoma at 6 months, then those patients get one additional scan at 1 year to see if they ultimately go on to resolution at 1 year. So 1, 3, and 6 months is how we've been imaging in the trial. And that's just mirroring how we image these patients clinically now at Stony Brook, at least after they have surgery or when they're conservatively managed.
And is
We're coming up on
criteria greater than 50% or?
For surgery, you're asking more than 50%. Oh,
yeah.
Yeah, in the trial that we're doing, again, we chose the 10 millimeter mark because on a coronal CT scan, that's fairly easy as long as the anatomical landmarks are standardized to measure from a core lab. We found that just the volumetric measurements are really difficult to make and difficult to assess accurately in any type of automated way. And so for a core lab to go through and hand trace all the subdurals and get a true volumetric measurement is going to be really challenging. For patients who fail and go to surgery, again, one of the potential points of criticism for these trials is that can be a fairly objective measure, or subjective measure, when these patients have to go to surgery under no set criteria. So when a patient fails and has to undergo surgical rescue or surgical reoperation after an initial operation, what we ask is, was this done because the patient deteriorated from a radiographic standpoint, meaning was there subdural vigor and was that documented on CT? Did the patient go for clinical reasons, meaning their symptoms became intolerable or worsened, or both, or other? So the sites have to indicate why surgical rescue was performed in these patients. But again, that is something that potentially could be a difficult endpoint, but we encounter this all the time. So in aneurysms, target aneurysm retreatment oftentimes is used as an endpoint. In cardiology, target lesion retreatment, so angioplasty, re-angioplasty, and all of the drug-eluting stent trials was always an endpoint. So it's a situation that's challenging to deal with, but one that we've been encountering before in device trials, so not insurmountable.
We're coming up on time. There's still a number of questions in the chat just talking about technique and the degree of embolization. And obviously we don't have the answer to that, as you've already mentioned. Is there a plan in the trial to analyze that, the correlation between embolization, penetration, for example, and the outcomes? I know there's some preliminary work on that out of Phoenix, but is there any plans to look at that?
Yeah, so the Bureau did a nice study showing that embolization at 2 branches was superior to embolization of 1 branch in terms of resulting in complete resolution of the hematomas. In addition, in our group, my research scientist associate, Dr. Sedastavan, has looked at our medical management versus endovascular management patients, so patients who were just embolized. And in a large cohort of patients who were just embolized, it does look like the surface area of embolisate is calculated from the DynaCT segmentation, correlates with complete resolution of the hemorrhages, and he's preparing that data for presentation and publication. So we'll see, we'll have a large group of prospective data that we'll be able to analyze that from in the trials, but that is something that is we're looking at. The time course of evaluation from 1, 3, and 6 month scans, and the degree of penetration of embolic, the surface area of the embolic, number of branches embolized versus resolution, also bilateral or unilateral treatment and resolution as well.
Nice.
Great.
Perfect. Any other questions, Cliff or Steve?
No, I think we answered most of the questions from the chat, as well as those that have been previously prepared. In the trial, are you also including the pain scores with respect to the chronic headache perspective? Because I know once you embolize the dura, that can definitely help with some of the pain control for patients. Is that something being monitored?
We haven't incorporated HIT scores or anything like that in this trial. It's a really good thought, and in retrospect, it would have been great to include. At the time that we were doing this, it wasn't something that we really analyzed in that great of detail. But certainly, since the single center data have all come out, and based on our clinical experience, headache resolution is one of the very first things we see after embolization of these subdurals, which is pretty significant and interesting. And in fact, the Bureau has a nice study that they published where they looked at patients who had chronic headache that predated their subdurals, so patients with chronic headaches that were 2 or more years before they presented with their subdurals. And what they found is that after MMA embolization, not only did their headaches from the subdurals go away, but their chronic headaches also went away if they had 2 branches embolized. So there's really some intriguing data in regards to that concept.
Dave, do you think we're going to be embolizing people for migraine in 5 years?
That's something that is under consideration, is in the midst of a feasibility study right now. Yeah, that's starting soon, likely, but it still is in my works.
Wow.
All right. I think that's maybe a good place to leave it. And thanks so much again for being with us, Dave. Thanks for the great work on the study, and congratulations on you and Adam for pushing across the finish line. We really look forward to the publication of it. So thanks for being here.
Yeah, thanks so much for having me. Really appreciate the opportunity.
Okay.
Thanks, Dave.
Have a great day, everybody.